and that's okay. But welcome everyone to the 4th general meeting. We're already halfway through the semester, so that's crazy, but we're doing good so far, and I'm happy to see so many people still attending these GMs and at these events. So without further ado, we'll just kind of go on to the next slide and get started. Today's meeting is going to be super awesome, so we want to get to that speaker as fast as possible. But before we do that, hopefully everyone here knows, and I'm sure you guys do, that local dues and national dues are required by tonight to join UT AMSA officially. So if you haven't paid yet through Venmo or the national dues, please do so immediately. You can access these links from any of the previous GM slides, and if you have any questions whatsoever, don't hesitate to ask any of the officers. But Armand, the secretary, is your go-to guy, so definitely check this out if you haven't paid dues yet. And another thing that is due tonight, some great opportunities are closing for AMSA teams. We have the AMSA Health Committee, which is applications are closing tonight, and we will be sending out those acceptance and first meeting emails later on. So we've gotten tons of responses, but we could always use more people, so please do that. And also, Whole Human Advocacy, they were formerly known as AMSA Advocacy, and fortunately, they have sent us a fantastic little poster with their application link and their social media and email contact information. So if you want to get more involved with health literacy and kind of policy making, they have a couple of projects ongoing, so please check them out there. And they're always looking for new members. And the last thing I want to mention is that the Kaplan scholarships are also going to be due coming up in the next couple weeks. So far, we haven't had many, and I say we haven't had any, applicants yet. So if you're interested, I would be happy to talk about this more. We already have a video out on our YouTube page kind of describing it and the options available, but definitely check out those Kaplan scholarships because that's essentially free money. And so please apply. It's well worth the effort. So as usual, please ask questions if you're interested in. And lastly, we do have our Discord, which many of you all are already in. This is just a final reminder that we have tons of resources and ways to get in contact with us. YouTube is our newest platform, so definitely check out all of this stuff if you haven't already, because we have tons of opportunities and resources available to y'all. So we want to make sure that y'all are getting access to it in a timely manner. So definitely join us and start getting to know us.
Okay, just a regular reminder, utmsa.org is a place to go for anything related to AMSA. Just to highlight a couple things, remember the calendar is where you can sign up for events. Every event opens up 8:30 a.m. the week before. 2 other really big things, the gallery as well as the forum, check those 2 out. You can get points for posting on the forum. You can get points for sending in pictures to Garrett for the gallery. So those are just some other great ways to kind of get engaged with us. Okay, and Famsa. Famsa groups are kind of all sorted now where we should be kind of in the role with it. Anything that you could possibly need for Famsa is either in your email, in the Discord, or on the members page, so definitely go check that out. Please pay your dues. I will have to remove you from the program if you don't pay your dues, so definitely do that ASAP. Like we said, those are due tonight, so get that done. If you participate or donate in the COVID fundraising gaming tournament that Anthony will talk about later, you can get a Famsa points. That's great. And if you're still looking to get involved with Famsa, that application will close tonight at 11:59. So please go ahead and put that application in if you're interested. Let me know if you have any questions.
Awesome. Yeah. So for our event updates, again, we just want to reiterate that we do have some policies that are really critical that everyone abides by. So these are in addition to UT's policies. They're largely the same, but specifically really require that you'll enforce that anytime you might be interacting with other individuals on campus.
And here's your gentle reminder to go out and do proactive community testing if you're here in Austin. They did change their policy, so you can actually get tested once per week now. So get as many tests as you need.
What's up, guys? I hope you all are doing well. So our first event this week is on Friday. It's Scriblio. There's still a lot of spots left on there, so if you want to sign up, go ahead and do that. Sign up sheet will close tonight. Next week on the day before Halloween, we'll be having trick or treat at UT Tower. So we'll be handing out candy in front of the tower. So be sure to wear your costumes and, just have some fun if you want some candy. Then we have Halloween movie night, which is pretty self-explanatory. And then finally, we'll be having an Among Us social. So that's going to be pretty popular. So make sure you look out for the sign-up sheet for that.
Hi, everyone. So MR events coming up are our medical student panel, which is it is next Tuesday. Unfortunately, it's not going to be a collaboration with UH anymore. It's just going to be UT AMSA alumni, but it's still going to be awesome. So definitely come out to that. We have our second MCAT workshop of the semester on November 3rd, and then a student research panel following on November 9th. And then just other general updates. Again, keep attending those Kaplan events. If you are interested, send me a screenshot if you'd like that bonus point for up to 2 attendances. The medical media challenge, again, those checkpoints that are optional are on the calendar for you to just follow along, just to make sure you're keeping on track with listening to the podcast. Socially distanced shadowers, I hear that a lot of you guys are participating in that, which is awesome. But again, please reach out to Lana if you have any questions about that program. And then lastly, again, if you would like just someone to talk to about pre-med stuff, you're more than welcome to reach out to me. Just shoot me a DM and we can definitely have like a one-on-one call or whatever to talk about anything and everything.
All right. So for our upcoming events, we have our 3rd committee meeting on October 26th, which is coming up very soon. And then also our last CTFB, which is coming up on November the 5th. Also, we've started to get our OAs involved, and Joyce has 2 events coming out, which is the UT Farm Stand Gardening, which is right on campus, and it should be really easy to get to for you guys. And also Peace Park Volunteering, which is really close as well. And then after that, we have our virtual Thanksgiving holiday cards that we usually do every year. And so we do have some really good events that are both virtual and in person for you guys.
Yep, and just to sum it all up, resources recap, we have the clinical volunteering database, really useful for using Austin, trying to look for shadowing or hospital-related volunteering. And then lastly, the non-clinical and virtual volunteering database. All of those are on the website on the members page, and soon the events will be added to the calendar itself. So that's something to look forward to.
So the makeup meetings have been going really well. If you do miss a meeting or you just need a meeting point, you can come out to those. They're every other Thursday. Also, if you're interested in buying old merch or merch from other years, you can check out the merch store. If you are a paid member, then you have paid for the general member shirt that we're all wearing. So please do come to one of the merch pickups if you are in Austin to get your shirt before it is too late. And if you aren't in Austin, I will make arrangements either next semester when we can see you in person. And then lastly, I wanted to mention our YouTube channel that Garrett and I have kind of worked on together. Some videos have been uploaded. The first 3 GMs are uploaded on there if you want to check those out.
All right, so coming up this weekend, on Friday, we're holding the COVID-19 Relief Online Gaming Tournament. So the deadline ends tonight at 11:59 p.m. So if you guys need some points or even the mandatory Famsa point just by donating, you're able to get those points and then also have an opportunity to participate in the gaming tournaments coming up. We'll be having our committee meeting on November 2nd. So if you guys want easy points while giving feedback, just come out to that. And then because of the great turnout from the cold cookie about a month ago, we'll be also holding a Chipotle profit share next month on the 15th. So come out if you want to come support AMSA, which should be held from 5 to 9 p.m. Just a quick interjection before we go to the guest speaker. I just want to hype up the gaming tournament just a little bit more. I don't know if Anthony mentioned, but we are raising quite a lot of money. So we really want to encourage that. Anthony, I don't know if you want to share how much we've raised so far. Right. So from what has been committed and projected, we have about $340 raised, which has far surpassed our initial goal of reaching $300. So I really want to thank you guys for donating while also coming out. So once again, the deadline is tonight. So if you guys want to continue donating or even want to participate, please sign up because you have an opportunity to get some cash money as well for the prizes from Scribblio and participating in the league tournaments.
So our guest speaker is going to be joining us in just a minute or two, but I can go ahead and announce her if you would like to go to the next slide. So our guest speaker for today is Dr. WilliamsBrown. She is a professor and physician associated with Dell Medical School here in Austin. As you can see, she is an OBGYN, and she also has a specialty in oncology. So she's going to be joining us very shortly by 6:45. So if everyone just wants to hang tight, or if anybody has any questions about maybe what we just discussed in the slides, please ask those questions now.
Officers were too fast with the updates today. That's okay.
What's everyone's favorite ice cream flavor? Put it in the chat. Mine's coffee. Is sherbet even like ice cream though? Interesting.
Debate night question? Does sherbet equal ice cream?
Ooh.
Good idea.
I think Philippe just asked a great question. If I am not on campus this semester, can I still join? You can definitely still join. You do not have to be in person to join AMSA, and a lot of our events this semester are virtual, so you can definitely still participate.
And also, while we have time, we sent out a little checkup poll in the very beginning, and I love this perfectly normal distribution. But yeah, just some extra info, and I'm glad that a lot of y'all are doing pretty good. But again, we are in a tough time in the semester, even without COVID. So always reach out to those who are important to you, get that support. Yes, it is a little right skewed, but you can say that those five people is still part of the normal distribution.
Someone in chat asked when the points will be updated for the donations. Those points should start being inputted starting on Sunday after the tournament ends.
Up? Am I sharing it? Okay, great. All right. So I don't know if I've already been introduced, but I'll just say who I am already. I'm Yvette Williams-Brown. I'm an associate professor in the Department of Women's Health and also the Department of Oncology here at Dell Medical School at the University of Texas at Austin. And I'm a GYN oncologist. So my understanding for the main purposes of this meeting is to, or at least me talking to you all at this meeting, is to give you all a little glimpse of what it is that I do in medicine, and also to answer any questions in terms of, you know, my journey there, and hopefully give you all some good inspiration and things along the way. So first of all, just to give you an idea of what gynecologic oncology is, it is a specialty that is specifically focused on the diagnosis and treatment of a female reproductive tract malignancies. So it is something that involves not only surgery, it also involves chemotherapy, and it also is, GYN oncologists are really crucial in terms of managing conditions that require a multidisciplinary approach, including radiation oncologists and other supportive team members, such as those who work in nutrition or genetics and so forth, because as many of you may or may not know, cancer is obviously very complicated, and having a very complex condition like cancer requires a multidisciplinary approach where you have multiple people that have different expertise, and having the combination of all of those people with those expertise working together towards a common goal is really what helps patients to be successful, or gives us a chance to be successful with something so complex and so difficult to treat like cancer. So GYN oncologists do that, at least in terms of women's reproductive cancers. So it is a specialty that occurs after the specialty training in OBGYN. So OBGYN is a 4-year residency after medical school, but then GYN oncology is a fellowship that takes usually anywhere from 3 to 4 years, depending on where you train. And during that 3 to 4 years, usually there's a year or 2 of research that's involved, whether it's basic science or it could also be clinical research. But then the remainder of the time is focused on the specific surgical skills and techniques that are important in GYN oncology. Some of that overlaps with things that some people may think of in terms of general surgery or urology or colorectal surgery, but really some of these skills are important for the treatment of gynecologic cancer. So although I don't do bowel resections for everybody, it's not like I would do a bowel resection on anybody coming in, but sometimes in the care of a patient with a malignancy, a bowel resection may be necessary. And so I'm trained to be able to take care of the issues as it relates to gynecologic cancer. All right, so moving on from the basics of that, I just wanted to tell you a little bit about me. And I am right there in the middle. I'm my mom with my grandfather and my sister here. My dad was in the military, and so I was born in Germany. We grew up, or I grew up multiple places until we settled down in Alabama, which is where my parents are from. And I grew up there from about 3rd grade until high school. So I don't know if any of you are familiar with Alabama or not, but I grew up in a very rural town in Alabama where it was very, there weren't a lot of examples or people in terms of like medicine. So I'm a first generation college graduate, first in my family to be a physician. And my mom always said ever since I was a kid that I always said I wanted to be a doctor. I'm not really sure where I got that from or why, but somehow it was a seed that was planted in my head. And somehow I guess I was probably unwise enough to even really know what I was getting into, but I had it in my head that I was going to do it, and I set myself on that path. And so, here I am in this complex thing called medicine. As I go through some of these pictures, I'll just sort of try to give you an idea of what it's like on a day-to-day to do my job, or, So I work very closely with residents, medical students, and other members of the OBGYN department. So here's a picture of me, and in the middle is one of the residents who's now since gone on to Emory to be an attending physician there. And then on the far left is one of our benign OBGYN attendings. And this is sort of a typical situation that we work together on patients that may have suspicion for malignancy. So OBGYNs in general they are trained, and which is why I work with residents. It's important for them to be able to recognize and diagnose conditions that could be malignant. So in the routine care of patients, there may be situations where they may make the diagnosis of a malignancy and then refer in terms of further management and treatment. So it's critical, even if someone doesn't plan to do specialized care in GYN oncology, being able to be triage and understand what those processes are for the next step is something the residents are learn along the way, and also even with medical students. So medical students rotate through GYN oncology here at Dell for about a week during their, I think it's like 6 to 8 week clerkship rotation. And so they get to spend a week with me and the team, and they're in different places like the surgery and clinic and seeing patients in the hospital and so forth. So, you know, again, even if you're not planning on doing something like a cancer specialist in women, it's important to at least be able to recognize and understand when there's a problem so that you can know when or how to get the person to the next step to get them the help they need. So this is the team, or a part of the team that I'm working with, or that I will work with. Starting from the front, that's one of our senior residents, Ruby Ronquillo. And similar to the other resident in the other picture, I have multiple residents that work with me, and the residents usually rotate through GYN oncology about a month or two at a time per year. So within a 4-year OBGYN residency program, there's so many different things about OBGYN. There's high-risk pregnancies, there's cancer in the reproductive tract, there's pediatric gynecology, there's reproductive issues, there's just routine clinic things. And because it's so vast, they need to learn all of those things. And so in the process of learning all these things, in each year of those 4 years of an OBGYN residency, they'll break it down to different rotations where they'll spend a month or two with GYN oncology, or spend a month or two in labor and delivery, or spend, you know, a month or two in OBGYN clinics. So this particular month, I was working with 2 residents. So there's a resident in the front and then the second from the back. So I'm working with a 4th-year resident, and then in this picture, a 2nd-year resident who's in the back. The person next in front of me is a nurse navigator, who is someone who works for the hospital, whose primary job is really to be able to help patients better understand what's going on with their care, and really to escort them, so to speak, through each phase of their treatment. There are many things, as I said before, that are important for patients to do and people to see, and because there's more than one person or entity that's important in being able to help patients get through their cancer journey. And that can be extremely confusing, especially if you're needing to get chemotherapy one day and then see a radiation oncologist another day and get a CAT scan. And particularly because I work in for patient populations that have, that are medically underserved in general, they may not have the support on a day-to-day basis to be able to really know and understand and recognize, you know, what all the steps or things that they need. And so Marcy, that's her job, to be able to help walk patients through this process. Behind me is a nurse who works in the clinic, and she is really the patient's first line, usually in terms of any questions, problems, issues. Like, her job is extremely busy in the sense that she's working day to day and hand to hand with a lot of the patients as they go through treatment before surgery and afterwards. And then in the back, there is a physician assistant who works with me, and she not only sees patients in the clinic with me, but also can help with procedures in the OR, and also see patients in the hospital. This is just another picture of me and 2 of our fabulous nurses who work in the Seton Clinic, where I see a lot of the patients who are medically underserved and who are receiving care through the Travis County Medical Assistance Program. Also, patients with insurance or private insurance can be seen there as well. But they're, again, similar to the other nurse in the other picture, they are integral to be able to help me, organize the hundreds of patients that we're responsible for throughout their treatment, getting new referrals in and making sure their treatment is sort of being run smoothly. Because of COVID and everything, many of our visits have had to be converted to telehealth. And as you can imagine, although a lot of things shut down during COVID, cancer didn't. So that was the one thing that really didn't seem to care whether or not there was COVID or not. So if someone had cancer or somebody needed chemo, it was very tricky and challenging because, obviously we didn't want people to be sick, but we also had to recognize that patients even had, possibly even greater risk of a actual threat that they had going on currently with cancer. And so sometimes we could manage any symptoms or side effects and things remotely. And so that's me on a headset talking to patients. And we were still actually seeing patients in person because if we were doing surgeries, it's hard to do an exam over the phone or virtually. So many times we still had to see patients and be able to do those things. And obviously we can't do surgery remotely, but we were able to manage these things and modify it to where certain things like giving results or just checking in on patients and how they're managing medications without having them to come in. This is a picture of me and part of the team members, another one of our residents on the right and in the back, a medical student and the PA right behind me. So every week, and you can see in the bottom right corner, there's a computer and a conference microphone or phone set up. So once a week, we have a multidisciplinary meeting where we review patients who are on treatment for cancer. And at that meeting, we not only have the team that I work with closely, residents, medical students, PA, but also the clinic nurses who are in the clinic and the radiation oncologist, the pharmacist who helps to manage and advise patients and us on chemotherapy and side effects. We have work with geneticists, dietitian, social worker to help with psychosocial needs. So there's a number of us who come together and we go through each one of these patients to be able to see, well, what is happening with this person? Even if they're doing well from a physical standpoint with the chemotherapy, if the doses of the drugs are okay and the pharmacist feels as if they're tolerating them well, we can check in with the social worker who may be seeing them on a psychosocial level and saying, well, how are they doing with their cancer treatment? Are they being able to cope with this? Are they, having some issues in terms of depression or problems sleeping? Or the dietitian may say, they're losing too much weight, maybe because they have a loss of appetite. What are some things we can do to try to keep their nutrition and their weight up? So that means that I don't have to do all those things. It's not like I have to be a nutritionist, or I have to be a pharmacist, or I have to be, everything for that person. That allows me to really be able to focus on the strengths that I have. And then it allows other people to be able to focus on the strengths that they have. So collectively that we can actually be a better resource to the patient as a whole instead of, treating our profession or our lives as if we're like an island. When we work together, we definitely have a much better outcome than if we're isolated. So this is us here in the OR, which is also another big part of what I do. So about 2 to 3 days a week, I'm doing procedures in the OR. Usually my biggest day in terms of surgery is all day on Monday. Tuesday, half day, I see patients. Wednesday, half day, I see patients. Thursday, half day, I see patients. And then on Friday, sometimes I'll do cases, and sometimes I'll throw in some minor cases or a half day of surgery during the week, sometimes on a Wednesday. But anyhow, during the OR, again, working with medical students, residents. We also have surgical technicians who are important in terms of making sure that we have the right instrumentation and things we need throughout the case. And so it's also a very exciting time in the sense that we get to, or at least I like it because I like to do procedures. It's a little bit of a mixture of, mixes things up during the week besides talking to patients on the phone or seeing them in the clinic. So now I'm going to start showing some pictures of like things coming out of folks' bodies. So if you don't like seeing that, you may want to not look at it. A lot of strange things can grow from the female reproductive tract, as you can imagine, or at least as I will show you here. Not everything that grows is cancer. So sometimes we just don't know until you take it out and have the pathologist look at it under the microscope. So many things that I take out usually are masses. And so this is one particular mass that turns out to be, it was not a cancer. I don't know if my arrow shows up here or not, but what's being held here by the person's hands in the clamp is actually the uterus, the body of the uterus, and on the sides here are the ovaries and the tube. And what's coming here in the bottom really is the cervix. So the cervix is normally about a third of the size of the uterus. So you can see how this is extremely distorted. It's much, much bigger than just the uterus itself. But, you know, many times patients can present with things like pressure and like a mass or a feeling of fullness of something growing, almost like a baby or a baby's head, you know. So this needed to come out, and thankfully it was not a cancer, but it was a growth that clearly was not normal and just needed to be removed. Here's another growth. This is coming from someone's ovary. So typically an ovary is about the size of a walnut in a woman before menopause, but it is before menopause about the size of a walnut, but then after menopause it's about the size of an almond because it shrinks. I can't remember if this woman was before menopause or after, but anyhow, obviously it's not right. You know, you can see that this mass had grown much, much bigger than what it was supposed to be. These things tend to be like, sort of like a water balloon. So for the most part, they can be contained. So our goal usually is to remove it intact and not pop it and spill it so that it won't just spread through the person's body. And I can't remember if this was malignant or not, because sometimes it's benign. Sometimes it's just a big mass that's just growing that could be cancer. Sometimes it is cancer though, but the only way we know is removing it and then have the pathologist take a look at it. I think I have another picture of that thing. Once we removed it and took it out, it, you know, could barely fit the bucket, you know. What's interesting is when I have medical students in the surgery, what we do is we remove it and we send it to the pathologist while the patient is still asleep, because that way they can cut it open and take a quick slide of the mass itself and look at it and tell us right there while the patient's asleep whether or not it's malignant or not. That can usually help guide and direct us on whether or not we need to do additional biopsies to see if there's any evidence of spread somewhere else microscopically. So a lot of the medical students usually like going down there and see them pop it open and make a slide and see what's going on in there. Sort of like cracking open an egg or something. So here's another mass. Here's on the right, one of our surgical technologists. In the middle is a resident, on the left is me. And here's another mass. I guess it's sort of like what we do is taking out masses of things, usually from the ovary or the uterus. And so here's another ovary. And then this is another ovary. Because it's important to try to keep these things together so as to reduce the chance of anything just sort of, if it is a cancer, to not spill it. we have to make a pretty big incision, usually an up and down incision that gives us the most room to be able to lift that out and to remove it intact without it spilling inside the patient's peritoneal cavity. Let's see, what else we have here? Oh, this is a benign tumor. So this is what you would call a dermoid tumor, but there's some tumors that occur that, you know, are just weird and sort of funky, and this is one of them. So these are the types of tumors that can produce, it comes from germ cells. So it's the same kind of cells that can create an embryo, but something went wrong with the cells and they get all wonky and they just grow this tissue out of control. So it's not like a formed person, but it's just parts of a person, because it's the same tissue that creates hair, or the tissue that creates fat, or tissue that can create thyroid tissue. And so these masses are pretty interesting in the sense that they can be like a cystic mass, and then when you open it, there's hair and teeth and thyroid and fat. So they're sort of weird masses, but not cancer. But they're always sort of interesting when you think about the fact that all those all those layers of cells, or those cells, have that potential in the ovary, and they just get a little crazy and start creating their own thing inside the ovary. And so as I'm coming to a close, other things that, I guess these are my own growths that I made. My two boys, they're 6 years old. So in addition to being a mom, I'm also, well, in addition to being a physician, I'm also a mom and a wife. I had my two boys when my first job outside of fellowship, and that was the book that I read in their book club or reading, you know, Friday reading thing, that My Mom Has Two Jobs, which is a great book. Actually, it talks about how, you know, my mom's a nurse, my mom's a doctor, my mom's an airline pilot, and she's my mom, and all those things. So I thought it was a really cute book that I bought or I read for my kids at their school. And so pretty much that's me in a nutshell, and what gynecology is in a nutshell. Obviously, I didn't cover every single thing I could possibly ask or I guess tell about myself, but I wanted to give an overview of sort of what it's like doing what I do and how I got there, and I'm happy to answer any questions.
Well, thank you so much, Dr. Williams-Brown. That was super interesting. At least I can say so for myself, and it seems like from the chat a lot of people agree. But I do have a little bit of a running list of questions that people have asked throughout your presentation. So just kicking things off, I guess I'll start with the questions that were kind of about the last few slides that you showed of some of the masses and example cases. And so a question that occurred a couple of times was just, how do these masses grow to be so large, and how do they not damage other structures around it? How do they even fit inside of a person, etc.?
Well, as you can imagine, you know, women's bodies are sort of meant to grow stuff, right? I mean, people, you know, have twins, triplets, quadruplets, more. So part of the issue with these growths that can come from the female reproductive organs is that our bodies have the ability to sort of hold these things, and sometimes until they're really big, where they're causing pressure on things like the bladder or the rectum, or people feeling distended or feeling like their belly is getting too big, that they don't even know it. So something like the size of the oranges in your pelvis, you may not have any really major symptoms. And some people have said, you know, especially like when you see that big mass of somebody like with a big basketball size thing, you think, how in the world could that happen? But I can't tell you how many times people have seen other, you know, healthcare providers, and they're saying, oh, you just need to lose weight, or, you know, you need to stop eating so much, or whatever, you know, because it could be mistaken for other stuff. So, yeah, our bodies are pretty amazing in the sense that it can, you know, in your abdominal cavity or peritoneal cavity, just like a baby growing, it just sort of pushes things out of the way. And a lot of times it's only until the extreme that people realize, get imaging like an ultrasound or a CAT scan, that recognizes there's something else going on in there.
Awesome. And another similar question, and I think this was asked by Simran. So Simran, if you want to elaborate on this, your question was how do you define the parameters of a tumor / mass? I don't know if you have anything else.
Well, so a tumor or mass is really just sort of like an umbrella term to really describe any growth that's occurring in the body. So, you know, some tumors are benign and some are malignant, sort of like a mole, you know, like if you have a mole on your hand, that's a growth. That's not a cancer, but it could be, like if it was, say, like a skin cancer mole. So what defines whether it's malignant or not is based on the pathology, which is when the histology of the tissue is evaluated, and then look for certain features like invasion into the deeper tissue and also features of the nucleus and all those different things. You only know if you have a tumor usually by imaging, like a CAT scan or an ultrasound, although in physical exam can usually be one of the first clues that there's something going on. It can be confirmed with more advanced things like imaging.
So I guess kind of jumping back to the top of our question queue, this is my own question. How many patients total across, I guess, all of the several clinics and hospitals that you do practice at do you typically oversee, like at one time? And how do you manage what I'm assuming is a large number of patients?
Well, at the current moment, I'm the only GYN oncologist in our department, but that is going to change come June. Typically, there's 2 of us. But for one person, it's a bit of a heavy load for an academic person who not only just sees, because if all I did was see patients, that's one thing. And some people do, like in private practice, that's all they do is see patients and operate. But in addition to seeing patients and operate, I also serve on different committees, like the admissions committee for the medical school, or also participate in research. So it doesn't, it's not really meant for me to do this all the time. That being said, I probably have about 60 or 70 patients who are actively on chemotherapy at the time. And then there's even more patients who have surgery that are not cancer, or patients that need to be evaluated to see what procedures or things they need to do. So I would say I see about maybe 20, 25 patients a week in the clinic, and I do about 5 to 6 surgeries that last anywhere from 1 to 4 hours a week. So a lot of that is patient care, but that's mostly because it's just me right now. So hopefully with someone else, I can use some of those weeks to do more things like research and things outside of just clinical work. Oh, and the way that I'm able to do it is because I'm not just doing it by myself. So as you saw, residents, medical students, physician assistants, nurses, you know, the multidisciplinary team is really key. And the only way really that I'm able to actually do all these things, there's no way I could possibly do every single thing for all of the patients. But because we work together and everyone is able to provide their level of expertise, I'm able to do my part.
Cool. So the next question is, how has COVID-19 changed how you interact with patients, dealing with health insurance and patient demographics?
So I don't know if those are all supposed to be related, but let's see. Whoever answered that question, can you elaborate a little bit more? Were those separate, or were you? I just want to make sure I understand it.
Yeah, they were mostly separate. I was just kind of listing things that, you know, could have been affected. But
okay, got it. Because I wanted to make sure I didn't miss that. So in terms of COVID-19, you know, from the beginning, there were a lot of restrictions in terms of surgery. There was a concern that we would overrun the hospital by doing procedures that that some people would consider quote unquote elective. So for instance, like if you needed your gallbladder out for, you know, gallstones, not like a super, super big emergency, but something that obviously somebody wanted out, they were putting off those surgeries because they felt like, you know, in terms of using space in the hospital, they didn't want to fill it up and have it for somebody who may need it for COVID. It started to spill over a little bit into cancer because, you know, as I said, some of these masses, we don't know if they're cancer, but, you know, you got to get them out just so you can find out. So it was a little bit of a problem at first, because then we had to really try to read the tea leaves and tell patients or tell the administration, who do we really think has cancer? Who do we really think shouldn't wait? And who are the ones that we thought, well, maybe they're not cancer and maybe they could wait. And so that was pretty hard. But then after about a month, they started opening things back up. And one of the first things that they allowed to start happening again was oncology procedures, just because in terms of, you know, the priority, you got to do those things a lot faster than, say, things like taking somebody's gallbladder out. In terms of different demographics, in insurance, you know, I'm sure some of you all are hearing a lot of things about with the election that, you know, the healthcare is obviously very complicated and it's very expensive. So it's impossible for someone to be able to get medical care without some sort of coverage or payment or something, whether it's government run or private or something. But someone is not really even feasible to say, oh, well, I'm just going to pay for chemotherapy out of pocket or radiation out of pocket. It's like $50,000 for one sort of round of treatment or something. And that's not even including things like surgery and CAT scans and things like that. So, you know, the nice thing about being in Travis County is that they do have a medical safety net program for patients who are uninsured or underinsured. That's not always the case. And so I just had someone say to me the other day, you know, who had a uterine cancer, who didn't live in Travis County, who didn't have access to that medical assistance program. And someone said, well, I just can't believe that in this country we have people who have cancer who can't get treatment. And I said, yeah, that happens like all the time. Like, it seems unreal, but yeah, there's a lot of people, if they don't have access to certain programs that can plug them into treatment, that even if I wanted to do it myself, I'm not able to administer chemotherapy or give the chemotherapy, or, you know, like I can only do sort of so much. Or if I decided I'm going to do surgery, I can't do it in my backyard. You know, hospitals and systems and things, they all have to sort of be on the same page. And it's extremely difficult for patients if they don't have that some sort of payer system to help them cover all of the things that are important in their care. There are many people that may not have access to treatment and could very well just die from their cancer in this country, which is really sad.
Thank you so much.
Mm-hmm.
That's great.
So our next question is, how did you know that gynecology was your passion, considering all the additional schooling and training? I love that Delmed is so multidisciplinary. So how is the research or patient care in your field changing today? It's kind of a multi-part question.
Okay. So, well, in terms of knowing that gynecology was my passion, I mean, I think that it really started with having a better understanding of some of the things that I liked about medicine. You know, whether I liked seeing patients in the clinic setting, or if I liked doing procedures, or if I enjoyed having long-term relationships with patients, or if I like to see problems and fix it and then move on. Or if you like high stakes stuff or things that are pretty low key, or, you know. So what I found is that I liked complex problems. I liked procedures. I wanted to do something that I felt like I could be good at, that I could be specific about, and not sort of like a jack of all trades type thing. So OBGYN, although I really, that was what I was very interested in from the beginning, from when I was at high school. I thought babies and pregnancy and deliveries were just awesome. And it's funny because I don't do any of that now, even though that's what drew me in. I don't even deliver babies now. But what I found I really loved about OBGYN, I found that, you know, seeing patients long-term, getting to, I've had a passion for women's health and being able to empower women in terms of being able to help them be healthier, because I really feel like many times women are like the cornerstone of their families, and sometimes they'll even sacrifice their own health and well-being for everyone else. So that was a passion for me. But what I found in gynecology was it had even more procedures, it had more complexity in terms of the medicine. And I really had a chance to get to know patients and really learn about them and their families and, you know, their dogs and pets, and see them long-term. And sometimes patients would die, and sometimes, you know, you would have to lose people, but it was just that more of an intense, deeper relationship with patients that I really enjoyed. And I sort of found myself drawn to it along the way. But when I was in high school, I don't think I even knew what a gynecologist was, but it's sort of following those passions and sort of recognizing, you know, which pathways were a better fit for me as I learned more about what specialties there were. So I think, you know, in terms of advice for you all, I think it's important to, you know, expose yourself to many different things. I mean, it's okay if you're like, I'm going to be a pediatric neuropsychologist or whatever, right? Like now, that's what I'm going to do, and that's the only thing I'm going to do. And that's fine, you may. But I would say just be open to the fact that you never know exactly what you're going to do. You know, I don't think I would have known I would have done that. It's close, but, you know, I'm very happy with what I'm doing now. In terms of the second question, Dermoid, multidisciplinary, there's a lot of things that are changing in terms of the field of gynecology and oncology in general, just because of the differences in, the new advances in terms of molecular diagnostic testing and targeted therapy, and cancer therapy is becoming, you know, very molecular based, which is great. So that is changing by the day.
So our last question, as we are approaching the end of our time, is how do you manage having 2 children with such a time-demanding career and continue to balance family life and your job?
Well, I could just say that some days you don't feel like you're doing anything the right way. You know, when you're at work, you feel like you should be at home. And if you're at home, you feel like you should be at work. And so sometimes, unfortunately, that doesn't always work out. And so I don't know if there truly is a quote unquote work-life balance. But I think when it comes to life in general, you know, I think the important thing is that, you know, stuff is not always going to be a perfect thing. You know, you don't think, you think, so when's the perfect time to have a kid? When's the perfect time to get, you know, sort of settled down with a person or whatever? There may or may not be a perfect time. And I think that you can prioritize the things that are important to you in such a way to where you can still give the time and attention to the folks who you care about and who care about you, without necessarily compromising the stuff that you want to do. I mean, when I leave this meeting, I'm going to go home and I'm probably going to hang out with my kids and listen to them talk about their day and what they did in school, and read a story and talk about all those things. And, you know, yeah, I probably have some charts I have to finish and emails I have to get to, etc. But, you know, you have to just sort of prioritize things in the moment. And when I'm in the OR, you know, obviously I can't not pay attention to this person who's open right in in front of me, you know, if somebody's calling me about something that's happening with my water heater or something, you know. So you can only do so much with the time you have, but I think some of the key things that are important is really getting a support system. I really wouldn't be able to do it without the help of my husband, my support of my husband, you know, the people who help us take care of our kids. And we have like an army of folks that I feel like, you know, I have a babysitter and a nanny and, you know, it's just all kinds of support and help to be able to really just do things day to day. So just like how I can't take care of all these patients by myself, I think it's important for me to have a support system even at home to be able to just do things for everyone else too. So working with a team and working with everybody is what really makes us successful.
Thank you so much.
Yeah, I think that was all of the questions in the chat. So if nobody else has anything to add, we just want to say thank you so much for taking time out of your very busy schedule to talk to us. And it was super insightful. It really was a pleasure listening to you. So thank you again.
Thanks for having me, guys. It was great. It was fun.
Bye-bye.
Okay, bye.
All right, so hope you guys enjoyed that. I definitely learned a lot. And it's hopefully, Aditi, if you can share that your screen on the last slide, because we have a last few reminders. If you didn't catch them before while we were waiting, again, hopefully everyone had their questions answered and was intrigued by the discussion. But as usual, please come back here in the next 2 weeks for GM5. But yeah, thank you all so much for coming. And again, pay dues. Apply for those applications and scholarships. And as always, we are happy to answer any questions you might have in the chat.